Thanks for joining me for this Part B, Allergy and Immunology, Common Rejections and Denials webinar. This webinar is designed for those who submit claims on the CMS 1500 claim form or the 837P electronic claim. My name is Mary Mucko. I'm a specialist on the Provider Outreach and Education team at WPS GHA. I will be your speaker today, and assisting me is my friend and colleague, Aline Sigler. We include this disclaimer in our education to remind learners that although we made every effort to provide current information that is correct and up to date, the information is subject to change, and it is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide final coverage, or we will provide answers to questions based on the facts that are given. CMS does prohibit the recording of this presentation for profit-making purposes, so we ask that you refrain from recording of any kind that includes screenshots and the like. Our agenda today reflects only the items that I plan to present now during this live education event. We ask that our learners carefully read the advertisements that we post, and this is to reinforce the specific education that we will provide during our webinars. The topics that we plan to cover today are specific to Part B, Specialty 02 providers, that's 03 providers, and that is Allergy and Immunology. Those who submit claims on the CMS 1500 form or the 837 professional electronic claim. Now, in that advertisement that I wrote and we posted out on our website and in our news items, I told learners that today I would be covering common rejections and denials, how to fix and avoid both, and then I'll provide some resources. This event, if time allows, will conclude with answers to the learner's presentation related questions. To fully understand rejections and denials, it's important to recognize the path that a claim takes, or what we tend to call the life of a claim. This is a simplified graphic on how a claim gets into the claims processing system, the multi-carrier system. Sometimes we call that MCS. The provider provides the service, submits the claim, and then our system will actually reject the claim, or might reject the claim, that is. If that's the case and there is a batch rejection, a 277 or 999 report generates. Now, most providers submit claims electronically. Very few actually qualify for a waiver under a law that prohibits payment of services or supplies that a provider did not bill to Medicare electronically. To confirm claim receipt, providers should use the 999 report. Use the 277 report for more specific information. Our data interchange or electronic data interchange staff provides helpful information in the Medicare 276-277 companion guide, and I've linked to it here on this slide for you. This will help clarify, and it will also further define the data content requirements for an electronic claim. And based on these reports, the 277 and the 999, you will know if the batch is rejected and if you need to correct or resubmit. Here's a simplified graphic that shows what happens to a claim that Medicare deems as unprocessable, and that's actually another word for rejection. Let's talk about that. Here is a slide that shows you the differences between a rejection and denial. And it's very, very important that you not use one instead of the other. In fact, you can't call a denied claim a rejected claim, or a rejected claim a denied claim, because they really are two separate things, very, very different things. I think a lot of us use those words interchangeably, and we really shouldn't. I catch myself doing it at times, and I need to step back and correct myself. So let's take a look at the difference. For a rejected claim, the claim is deemed unprocessable. That means it's returned on the front end. The claim has illogical information or something that doesn't make sense. Perhaps something is missing, or it's incorrect. Maybe it's in an incorrect format. For rejected claims, because they're never actually adjudicated, there are no appeal rights. You need to fix it and resubmit it. When looking at the remittance advice for a rejected or unprocessable claim, you will see the MA130 remittance advice remark code. And basically what this states is that your claim is incomplete or invalid, and that no appeal rights are afforded because that claim is unprocessable. There will also be a CO16 group code that appears on the remittance advice for a rejected claim. That means contractual obligation, and the provider is liable for payment. The patient is not liable. You need to submit or fix and resubmit the claim. For a denied claim, the claim is actually adjudicated. The services, either a claim line or the entire claim, will be denied because the claim fails to meet payment criteria. There's different types of payment criteria. It could be medical necessity or frequency. They're one and the same. That's a medical necessity denial when something has a utilization parameter attached to it. Perhaps it's denied based on law. It's a statutory requirement that makes that service or that claim not payable and denied. Maybe it's eligibility that is the reason for denial. In any case, you will find on the remittance advice an MA01, and this MA01 code actually provides information about the right to appeal the claim determination. For a denied claim, the patient liability is determined. This graphic shows the path for a processed claim. Again, the provider would provide the service, submit the claim. Medicare would either pay the service or deny the service, maybe not all of the services, maybe all of the services, but there is a determination of to pay or deny the service. In other words, that claim is adjudicated and a remittance advice is generated. Let's talk about the remittance advice just for a moment. Sometimes we refer to this as the remittance notice. Sometimes we just simply call it the RA. Most providers, as I mentioned, will receive or most providers submit electronic claims, and most providers receive an electronic remittance advice, or an ERA, as opposed to a standard paper remittance, or SPR. Now, depending on how the claim is processed, it may include information about any adjustments that are made to that claim or denials. It could also include information about something that's missing. Sometimes it provides notice about refunds and offsets. The ERA provides payment information about the transfer of funds and payment processing from a health plan to a healthcare provider's bank, or the explanation of benefits or remittance advice. Now, CMS used to publish a guide called Understanding the Remittance Advice, but here's where a change comes along, folks. Remember my disclaimer, I made every effort to make certain this was up to date, but CMS has discontinued the use of this guide. The CMS Remittance Advice Overview booklet is no longer available, and instead, CMS makes information about their ERA on their website. So I'll have Aline place a link to the Healthcare Payment and Remittance Advice webpage in the chat. And it is on this page that you will find information about the remittance advice notice. There are codes on the remittance advice that provide information about the claim. Claim adjustment reason codes, we call them CARCs, C-A-R-C-S. These explain why a claim paid differently than it was billed. And a remittance advice remark code, we call those RARCs, R-A-R-C-S. These provide more details about an adjustment that's described by the claim adjustment reason code. We also have another type of code that appears on the remittance advice. It's called a group code. These convey the financial responsibility for the unpaid portion of the claim balance. A CO stands for contractual obligation, and this means the provider is liable and can't bill the patient. A PR means the patient is financially responsible. You can find code lists, those RARCs and CARCs and group codes, on the Washington Publishing Company's website. This is a company that maintains the codes for CMS. Now, let me just add here that we do understand that some of the codes may be a little bit cryptic or they may seem out of date. And when I say out of date, what I mean is that some of the code messages that print out on the remittance advice include an outdated acronym. For example, there might be the acronym HICN, Health Insurance Claim Number is what that stands for. Well, we know that the Medicare Beneficiary Identifier has now taken over the health insurance claim number. Now, after reviewing the remittance advice, you're going to need to choose your action. For an unprocessable or rejected claim, you'll need to fix the error and resubmit the claim. If the claim or the claim line is denied, there could be multiple actions to choose from. You may be able to simply resubmit the service. You might be able to use a clerical error reopening process to fix clerical errors, and CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. And I'll talk more about that SIR process later in this webinar. Another action that you can choose from or consider, perhaps, depending if your claim is rejected or denied, is an appeal. And the remittance advice will provide appeal rights. And I'll discuss appeals a bit later in this webinar in addition to that SIR process. Registered users can use our transactional portal to render a clerical error reopening or to request an appeal. These are self-service tools that really do offer the most efficiencies. Our portal user manual provides illustrations and also step-by-step instructions on how to use the portal features. Next, I want to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim. For any of you that are not familiar with the acronym MAC, it stands for Medicare Administrative Contractor, and WPSGHA is the MAC for Jurisdiction 5, states of Iowa, Kansas, Nebraska, and Missouri. That's for Part B, that is. And then also the MAC for Part B in Indiana and Michigan. We also have cover the Part A facilities for all of those states, in addition to additional states that have chosen WPS-GHA as their MAC. We call these our legacy states. I talked a bit earlier about ways to fix clerical errors. This clerical error reopening process, or SIR, as you can see by the acronym at the top of this slide, is one that will allow you to correct human or mechanical errors. Clerical errors or minor errors are limited to errors in form and content. And omissions do not include failure to bill for certain items and service. Now, there are examples I can provide you for acceptable clerical error submissions. You can use this clerical error reopening process to correct mathematical or computational mistakes, transposed procedure or diagnostic codes, inaccurate data entry, misapplication of a fee schedule, or simply to fix a computer error. Now, there are examples also. If you look in that resource that I provided here in the last bullet on this slide, how to request a clerical error reopening is available on our website. It's just one of the many valuable resources. But that particular resource not only tells you examples of acceptable clerical error submissions, but those situations that cannot be processed as a clerical error reopening. Your handout includes the link to that resource. You can use the portal, as I mentioned, that secure portal for self-service to request a clerical error reopening, or you can request a clerical error reopening via telephone or fax. The portal user manual does provide instructions for doing it self-service, which does, as I mentioned earlier, offer the most efficiencies. For claim denials, most often you can request an appeal, and if that's the case, you will see that MA130 on your claim form. The purpose of the appeals process is to ensure the correct adjudication of claims. Physicians, suppliers, and beneficiaries all have the right to appeal claim determinations that are made by the MACs. And I think I just misspoke. I said MA130 is that notification on the remittance advice that provides the appeals rights. That's wrong. The MA130 is that message you'll find on a rejected claim. I want to correct myself and make certain that you know that the MA01 message is what you will find on the denied claim that provides those appeal rights. So I apologize for that. I did want to clarify. Now, the beneficiary or the representative can request an appeal on any service that's processed for them. Providers and suppliers can appeal services on which they've accepted assignment. But for unassigned claims, a provider or a supplier can actually act as the beneficiary's representative. But if that's the case, the beneficiary has to sign an authorization statement, such as the CMS 1696 form. It's an appointment of representative. Additionally, providers and suppliers are allowed to request a redetermination on an unassigned claim if Medicare denied the service as not reasonable and necessary, or if the provider or supplier billed in excess of the limiting charge. And if that's the case, the provider or supplier must refund any fees collected from the beneficiary. There are 5 levels of an appeal for Medicare claims. The first level is called a redetermination, and it is the only level, or the only level of appeal rather, that is rendered by the MAC. There are time frames that apply to each level of appeal when submitting them. Additionally, there's a minimum amount in controversy that applies to levels 3 and 5. You can combine like denials on more than one claim in order to reach that minimum amount in controversy. Here are a couple of resources for appeals. The first one listed here and linked in your handout is How to Appeal a Claim Determination. This is a resource that appears on the WPS-GHA website. Tells you how to appeal a claim, where to send it, and so on and so forth. We'll also provide you with some guidance if you wish to do this on your own using self-service tools available on our portal. The second bulleted item there, and it's updated annually, is one of my personal favorites that I like to share when I am giving education to learners in our jurisdictions. It is a fee-for-service appeals process flow chart. It is updated annual, and I love this flow chart because it's a real quick, easy to look at flow chart that shows all 5 levels of appeal, provides you with the names of them. It tells you the time frames. How long do you, the provider, have or the beneficiary have to submit the appeal? And how long does that contractor, for example, for redetermination, the MAC, how long does the MAC have to render their decision? Or how long does, the appeals board have to render their decision, so on and so forth. So time frames on how long you have to submit, how long the contractor or entity has to render their determination, and then of course there's information on that amount in controversy for levels 3 and 5. As I mentioned here, it is updated annual. Be careful at the end of the year if you're referring to this, because it takes a while for CMS to get this updated. Typically, but not always, the amounts in controversy may change from year to year. So that's really what you want to keep an eye on there. All right, the next portion of this presentation includes a discussion of the data that I used to gather information on common rejections and denials for specialty 03 allergy and immunology providers. The data that I'm sharing today is all specialty 03 submitted claims for jurisdiction 5 and jurisdiction 8. So that means the states of Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan collectively. And I pulled only Part B data, just as I advertised. This is a webinar for Part B providers. While the dashboard allows us to drill down by a specific state or states and even counties, I pull data for our entire jurisdictions, both 5 and 8. For those of you that are wondering what Specialty 03 is, it is a 2-digit code assigned to WPS GHA providers when they enroll. So during enrollment, providers self-designate a specialty. And while a provider can designate a secondary specialty, it is only that primary specialty, the one designated, self-designated during enrollment, that is used during initial claim processing. There are some situations where a provider will request an appeal and tell Medicare their secondary specialty, and in some cases Medicare can make payment based on that secondary specialty. So specialty code 03 is allergy and immunology. I pull data for claim dates, or claim submission dates rather, September 1 of 23 through February 29 of 2024, and that data was last refreshed on March 13 of 2024. So what this means is that any claims submitted for 03 specialty after March 13 are not included in the data that I'm going to present. Typically, common rejections and denials stay pretty consistent, so it doesn't change a lot. Now, this data that I'm telling you about, this data that I pulled, is actually available to me and my colleagues in it's called a claims dashboard. And it was created by our data and health informatics team so that people like Aline and me can go out and put in the searches that we want. So for example, I'm looking for specialty 03 claims. I'm looking for only Part B claims. I'm looking for claims in this state. I'm looking only for rejected claims, or I'm looking for denied claims. Those are the types of things that we could enter into this dashboard. And honestly, by the time we are finished putting in all those variables, or those filters, if you will, the information comes back to us just like that. It's almost instantaneous. So let's take a look then, just as I advertised, the most common or common rejections for 03 Part B providers. And here they are. The top rejections by reason are listed here, and we are talking about rejections. These are unprocessable claims, which means you need to fix it and resubmit it. Claim lacks information needed for adjudication. There was 251 rejections for the time period that I looked at, the data that I looked at, 03. Now this could mean a number of things, and typically there would be additional reason codes on the remittance advice that would tell you or give you a clue as to what's missing. So you'll want to look at that remittance advice and determine what's missing. Or you could look at the claim and make certain that you've entered all of the required elements on your claim. Another common reason for rejection is missing, incomplete, or invalid ordering primary identifier. 220 rejections. Make certain if there's an ordering provider for the services that you're billing that you are indeed including this on the claim. Make certain you are entering the primary identifier correctly, that all of the digits needed are there. Make certain it's not incomplete or invalid. The next one, claim denied because the information received was incomplete. Here again, if your claim is missing something, this may be a potential reason for rejection. Or perhaps this was a case where Medicare tells you you need to enter information into item 19 of the claim, and not all of the information was there. So it might reject. The next two are a bit similar. Claim must be submitted to Railroad Board. And the final bulleted common reason there on this slide is this claim has been forwarded to Palmetto Railroad Board, 19 and 16 claims. For this one, to avoid, you're going to want to make certain that your front end staff is asking to see the patient's Medicare card, or that you're checking eligibility. In this case, this is a beneficiary, a railroad retiree, so their Medicare claims need to be submitted to the Railroad Board. And if that's the case and you're looking at the Medicare card for those types of patients, or those patients entitled to railroad Medicare, it will state Railroad Board right across the bottom of their Medicare card. You might be wondering why we just simply rejected it's 19 claims, and for 16 claims we forwarded that claim on to Palmetto. Well, that depends on those agreements with the beneficiary's secondary insurance or supplemental insurance. There may be a situation where the trading partner agreement with Medicare says if you reject claims for any of our enrolled beneficiaries, we want you to forward them to Palmetto rather than just reject them. So this is part of that trading partner agreement. In that case, there would be an agreement. We do want those rejected claims forwarded, and there would be, they would enter into an agreement or a contract with Medicare, in this case WPS, in order to automatically forward those to Palmetto. So that's why this appears on two lines. Let's take a look at more common rejections. Claim must be submitted to the DMERC. That's the Durable Medical Equipment Regional Carrier, and WPS on their website does have lists of those services that must be submitted to and processed by the DMERC, the DME MAC, versus the MAC. This is one of those cases when I told you about that an acronym rather is out of date. We no longer use DMERC or DME regional carrier. It's the DME MAC, Durable Medical Equipment Medicare Administrative Contractor. So we do have on our website a resource or a page titled Durable Medical Equipment DME Claims, and I'll have Aline place that into the chat feature for you so that you can easily find that page. And for each state, then you can click on a link and see or view that list of codes that have to be submitted to the DME MAC versus to the MAC. Next rejection or common rejection reason is facility or lab name is missing. Our facility lab name is missing, or the address is missing, or the PIN is missing. For this one, you would look to the modifier 90 fact sheet. We have a number of fact sheets on our website that provide the do's and don'ts for using certain modifiers, and I can show you where to find the modifier fact sheets when I take a peek at the WPS GHA website. In fact, I'm going to show you that right now. I'm going to pull over. I've opened the WPS GHA website. This is the home page. You can actually go, if you're a searcher like I am, and key in modifier, You would need to choose your jurisdiction. I'm just going to select J8, and you can see the modifier fact sheets listed here. That's one way of finding them. And of course, I can go from page to page to find that modifier 90 fact sheet. I can drill down by entering modifier 90 and look here to the modifier 90 fact sheet. And this talks about the importance of entering that name and address on the claim form. It tells you what you need and where you need to put it and so on and so forth. So that would be a situation where you would use that. If you're looking for modifiers in general or modifier fact sheets in general, go to the topic center and choose claims. And you will see as you scroll down, we actually have an area here for modifiers, and this will link you out to all things modifiers, all of the modifier fact sheets that we make available on our website. I'm going to go back to the home page. So if I pull that over again, it's right there. Patient insured HICN, here's an outdated acronym, folks, and name do not match. The patient's name and the health insurance claim number or the Medicare beneficiary identifier have to match exactly on the claim. If the name on that Medicare card has a middle initial, your claim needs the middle initial. Next up, rejection, field 11 of, here's another outdated acronym, HICFA 1500. It's the CMS 1500, must be completed. You can't just leave it blank if there is no other insurance that's primary to Medicare or that could be primary to Medicare. You need to include the word none. And this is in the claim form instructions. Claim form instructions is found out in CMS's internet-only manuals. I've listed that as a resource for you a little bit later on in the handout materials. Invalid or missing modifier, 3 denial or rejections. I caught myself there. You will need to look at the service build and ask yourself, is there a modifier needed? Or perhaps you build a modifier and it was invalid. Next, unable to obtain primary insurer information, and that of course would pertain to those services, and you would need to look to Medicare secondary payer information, and I'll give you a link to that information when I cover the resources a little bit later in this presentation. So that takes care of the reasons for top or most common rejections. Here I've pulled for you a list of the codes that are commonly rejected. You can see the J2357, that's an injection. A couple or one code here is the 95117. That is a code that appears in the billing and coding instructions. A57472 relates to our local coverage determination L36408. And when you're looking, if you're looking to see if Medicare has a local coverage determination or if CMS has a national coverage determination for a particular code, remember that CMS made us remove all of the codes from our policies, but they still may appear in an article or an LCD article. That's the companion guide for the article. So I'm going to show you here the LCD and article lookup tool that's available on our website. So if I key that code here and hit search, 95117, hit search, this is going to bring back any matches where this CPT code is found. It's found in the billing and coding, allergy immunotherapy article. And you can see here is the just some of the CPT and HCPCS codes. This code is also found or referred to, or there's coverage for it, coverage parameters, indications and limitations for coverage in this local coverage determination L36408. And you can quickly link to the article by clicking on the links that we have provided here for you. It actually will take you, for example, if I open the billing and coding article, it will take you out to the CMS website, and then here is where you will be able to find that specific information for 95117. And remember, if you want to find a particular code or word, you just Control F, key your code here, I used the wrong code here. I used 951. Oh, I did. It's 95117. I apologize for that. And then by looking here and using these arrows at the top, you can move through the document to find all of the matches. Okay. So that's to find if your rejection or denial is due to a local coverage determination. So some of the other rejected codes are professional services for allergy and immunotherapy, not including provision of the extracts. You can see there is an unclassified biologic code here, J3590. What likely happened here is the description of that unclassified biologic wasn't included on the claim, so the claim was rejected. Some of the other codes that are commonly rejected are E&M codes, also spirometry test with a pre and post bronchodilator, and so on and so forth. So just some good information that I pulled for you, really easy or quickly available in that dashboard that I talked about earlier. Let's take a look at the denials then. Top denials or most common denials: collection of fee-for-service during periods of managed care. Beneficiary is a managed care beneficiary, so this would be an entitlement reason. You can see there are 3 different uh, duplicate denial related reasons for denials listed here on this particular slide. A lot of duplicates. If you have, or if you use a billing system or a billing service that automatically submits your claims every 30 days. If you haven't received payment on the claim, stop doing that. It's abusive. You need to keep in mind it does take Medicare some time to process the claim, and there are also payment floors in place. We can't send payment for a paper claim in less than 28 days. We can't send payment for an electronic claim in less than 14 days. So keep these things in mind and make certain you're checking to see if your claim has already been submitted. We're trying to avoid duplicate claims. These cost everybody money, both providers and the Medicare program. We do have a helpful resource available on our website. I'll point that out to you in a minute. Payment included in another service on the same day. That's a bundling denial. What you're going to want to do there, went too quickly, is check to see what the other services are on that day. Is this a situation that you can perhaps consider appending a modifier? Does your documentation justify use of a modifier to unbundle the service? Here are more top denials. This physician or supplier is not eligible to receive payments. That's one where you're going to want to check your provider enrollment guide, file to make certain that everything is up to date. Not covered when performed, referred, or ordered by this provider. So, maybe a number was transposed when you were entering, but maybe it's just simply not covered when performed or ordered or referred by the provider. Referring provider not eligible to refer this service. There are some resources that CMS makes available on who is eligible to refer, who's not eligible to refer. I'll point those out to you when I talk about the resources a little bit later in this program. Denied service. Units of service are exceeded. This would relate to the medically unlikely edits. You would look to the National Correct Coding Initiative edits on CMS's website. I have those, or a link to those later in the program. And finally, claim must be sent to the employer group health plan first. This is a situation where another insurance is primary to Medicare. So this would be an eligibility type denial. You're going to want to check eligibility for your patients to see where that claim needs to be sent first. Here are top denials by code for specialty 03. You can see some of them there, the 95117, the 95165, 95115. These are all codes that are listed or included or governed by local coverage determination L36408. The billing and coding guide that tells you the guidelines, the billing and coding guidelines that is A57472. And I just showed you how you can go out to our website on our homepage and use our lookup tool to see if a particular code is included within a policy or the coverage and indications included in the policy. The codes themselves are included in the articles. Other codes that hit the top denials are spirometry, percutaneous tests, uh, and so on and so forth. You can see there's a 99204, that's an evaluation and management code, that's a new patient code. These numbers here that are showing are the number of claims that actually denied. I mentioned to you that we can break down the data by state, by county. We could look by HCPCS code, by county by HCPCS code. We can also look at trending, and I want to show you an example of that. Here is a trending denials example, and this particular code description is the time limit for filing your claim has expired. No appeal right. There are no appeal rights for timely filing denials. We can easily find in that database that I talked about, or that dashboard rather, the claim count for the current 3 months is 52. The prior 3 months was 24. There's a difference of 28 claims, and the percent change is 117%. And then it shows us a visual when we're looking at this dashboard, and it will show an arrow up for an increase or an arrow down for a decrease. And you might be asking me, well, why is this important? We need to analyze rejections and denials to know what type of education to provide to our providers. And this trending helps us know, did it work, our education? Did it not work? You know, we can look at this over time to see how we are trending with either denials or rejections. So here then are some tools that I've included in your handout, things that I've talked about today for those common rejections and denials. The claim form instructions are included in Chapter 26 of the CMS Publication 100-04. And I want to show you that real quick. When you're looking at the CMS website, it's cms.gov. If you scroll down their homepage, you will find over on the right here under top resources, manuals, forms, and transmittals. And this is where you can choose a link to the internet-only manuals. This will allow you to look at CMS's internet-only manuals. And if you look at what I wrote up here, it's Publication 100-04, Chapter 26. Here is 100-04, the Medicare Claims Processing Manual. And then I can find Chapter 26. So a lot of times we hear providers say, where does it say? This is how we provide, where does it say XYZ and so on and so forth. So this is where you can find the claim form instructions. Now when you look at this, I'm going to make it a little bigger here. When you look at this, you might notice, for example, let's see here what I want to look at. I'll look at this one. You can see that this is listed by item number, and that corresponds to the item on the claim form. Item 1 is this, item 2 is that. Let me just do a quick find here. I want to look at item 19. Item 19 is used to report a lot of things. Okay, so if it goes in item 19 on a paper form, where does it go on the electronic form? That is why I like to give you this crosswalk reference. If you look at this crosswalk, and I don't know how long, it's probably easier just for me to walk you there. If you're out on the WPS website homepage, go to EDI and scroll down, and you're going to want Medicare EDI. This takes you out to our EDI webpage. And here is the crosswalk. And what this does is tells you or shows you, I'm going to look for, I'm going to scroll, so if that movement bothers you, look away, and I'll tell you when I'm there. I showed you item 19 and the claim form instructions. Here, you can look back if you've looked away, provides for you, if it goes in item 19 on the paper claim form, where does it go, in what segment or what loop does it go in an electronic claim, and then it provides for you the information that you need to place there. So if information is incomplete or missing on a claim form, this could be really helpful to you, a great tool. This is also helpful because it will tell you for all of the items on a claim form, is that item situational, which is an S in this status column, or is it required, which shows an R, okay? So does it have to be there or does it not need to be there? So that's that crosswalk, and you have a direct link to it. I got ahead of myself here. Okay, ordering. This is ordering and referring information. That was a common rejection or denial that I talked about earlier. So you can find the information on ordering and referring providers, which includes, I'm so sorry here. My scrolling button is, I bumped it. So this is where you can find those NPIs for ordering and referring to make certain that you're entering a complete and full NPI when it's needed. This is how to correct a rejected claim. This is a resource on our website, tells you listed by remarks codes. Remember those remark codes, those CARCs and RECs I talked about earlier, list by different remarks code. If you see this on your remittance advice form, this is what you need to correct it. So this is a great resource there for rejected claims. And similarly, we have listed by reason and remark codes for categories: bundling, global surgery, payer contractor denials, provider number denials, common claim denials. So this is where you would find on our website a great resource for that. And here's how you get to our resource. Some of the common rejections denials were MSP related, so I've included a link to that. If you're looking for live education to learn more to avoid rejections and denials, look to our live events webpage. Our recordings are available out on the Encore Presentations webpage for a period of 90 days. After that time, you will find them on our YouTube channel. So all of the links are included here. Here's a link to that LCD and article lookup tool that I mentioned earlier. Provider enrollment guides and resources. If you think back to some of the items I covered today, one of the rejections or denials was your provider wasn't eligible when these services were rendered. This is where you can find information for provider enrollment. Medicare secondary payer fact sheet is available on our website. This will help you prepare and submit correct claims for those Medicare secondary payer situations. Timely filing of claims. That was that trending example I showed you. I told you that you can't appeal a claim that's denied due to timely filing. This particular resource, and I'm opening it up on my other screen here. I'm just going to show you really quick. It's easier for me to search for it than it is to use the link and wait for it to respond. Okay, so here is that timely, and you have the link in your handout. Timely filing of claims tells you the patient responsibility for claims denied. You can only hold them responsible for 20% of what Medicare would have paid had the claim been filed timely and payment made. This explains that you have no appeal rights for claims denied based on timely filing. This section tells you if there's a third-party error. It doesn't necessarily mean that CMS is going to say that we're going to pay the claim if it's due to a third-party error. But there may be legit reasons why you believe that we should extend the timely filing unit. And this tells you here how to file a waiver to extend the timely filing unit. You actually need to submit to WPS's claims manager, and it tells you that right in this section, this information. Okay, and submit that, and it gives you the address. Remember that I'm on the J8 MAC Part B website. If I'm on the, so you see Indiana and Michigan here. If I'm on J5 MAC Part B website, you will see Iowa, Kansas, Missouri, Nebraska. Okay, but the same article. Okay, so you can move back and forth between each of our jurisdictions just simply by clicking on the jurisdiction here on this bar. All right, let's go back to PowerPoint. Here, oh, I'm doing it again. I am so sorry. Can't make my fingers work today. Okay. Some CMS website resources, the coverage database, how to use that coverage database. That is a national depository of all national and local coverage determinations. Even those articles, I pulled one of those open earlier when I showed you how to search for a code within a coding and billing article. This how to use the Medicare coverage database is an online educational tool which will walk you through how to use that searchable Medicare coverage database, sometimes called the MCD. Beneficiary notice initiatives. This will assist you when there are situations when your claim denies due to medical necessity. If you prepare and present a patient with a valid advanced beneficiary notice of non-coverage, then the liability for payment changes and you can bill the patient. Incarcerated Medicare beneficiaries didn't hit the radar for your specialty, but it has been hitting for a lot of other specialties. So I wanted to include a link to our webpage that talks about codes or claims or Medicare coverage for incarcerated Medicare beneficiaries. One of your rejections or denials was due to the National Correct Coding Initiative or bundling. So I provided a resource here where you can find links to the procedure to procedure edits. One of the rejections or denials was related to units in excess of the medically units were billed in excess of what's allowed for this service. That's the medically unlikely edit files. So I've included a link to that. The IVR is a tool that you can use to look for claim status and details. We have an operating guide available on our website, so that's a great tool to use for eligibility and to get more claim status and details. The same goes for, our portal. You can get that kind of information, eligibility, claim status, claim details, claim actions on by using our portal. And remember, we have the portal user manual available. If you are out on the WPS website, the portal user manual link is right here under this login box. It's available on every single page. So if you aren't a registered user, you should consider becoming one because those self-service efficiencies really do offer the quickest way to make corrections and request appeals. There is a more info button. It's a blue colored button currently in the user manual. When you're looking at claim details or claim line details and something denies, if you click on that more info button, it will give you more details about the denial. So let me give you an example. If your claim denies because it didn't meet the criteria in a local coverage determination, that more info button is going to take you to that policy. It'll open that policy up so you can see it right then and there, and you don't have to go looking. So that's a great functionality of the portal. Just as a reminder, I talked about the portal. I talked about the IVR, the integrated voice response. Self-service tools. Just back a couple of slides. These really are the fastest way to take corrective action. All right, we have just a couple of minutes for questions. Aline, do we have any questions thus far in the chat? And these must relate, remember, to the information I presented, and I can't respond to claim-specific questions. I have no way to check the information in the claims processing system to tell you what did or didn't happen. So in general, I can respond to questions. Aline?
Thanks for all that great information, Mary. We have not received any questions.
All right. Well, if you're like me and you walk away from your computer or tomorrow, perhaps you'll say, gosh, I wish I would have asked that question when I had a chance. You'll think of something and you'll wish that. I'll tell you in just a little bit how you can submit those questions.
Mary?
Yes.
We just received a question. Thank you, Estefania. Will you please provide more information about the NCCI edits?
Okay. Well, what I'd like to do is let you know that we have delved into the NCCI edits. And we have recordings available that really do it justice. I can't, in just the next couple of minutes I have here, but In a nutshell, the National Correct Coding Initiative was implemented by CMS to ensure correct coding. So there are edits set up in our system. There are procedure to procedure edits which will make certain that payment is correctly unbundled or is correctly bundled. So let me give you an example. There's two CPT codes for two services provided by the same provider to the same patient during the same encounter. Sometimes payment for one of the procedures will bundle into payment to the other. These code edits that are available on the CMS website actually tell you which code bundles into the other and whether or not, based on your documentation, you can append a modifier to unbundle and receive payment for both. There's also the medically unlikely edits, and these are edits that set a, a a limit on the number of the same service that can be rendered and paid by Medicare on the same day. So for example, if you do 8 of a certain lab test and Medicare says that you can only bill for 5 on a given day, you'll get paid for 5, the other 3 will deny, but you can request an appeal on those 3 that denied. You'll have to provide your medical record documentation, of course, to justify receiving payment for more than the MUE. Another type of National Correct Coding Initiative edit is an add-on code edit. There are certain codes that CPT stipulates are add-on codes. So those codes can only be billed, but only after the primary code is billed. And the CPT manual actually provides for you which codes are add-on codes to which codes that are primary. So take a look out in our, and I'll follow up following, oh, actually, it's already included here. National Correct Coding right here, this final bullet and sub bullet on this page, if I can get back there, is the National Correct Coding Initiative webpage. Take a look at that to find more information. And also you can look at the WPSGHA YouTube channel for some videos that we've done on the National Correct Coding Initiative. Some great information out there for you. All right. I've gone over just a little bit. Thank you so much for sticking with me today. Our greatest compliment is when our learners recommend our education to others. Please consider recommending our education to others, whether it's internal within your organization or maybe at a meeting you attend for coders or billers or those in your professional organizations or societies. This really helps us reach our goal to provide needed education to all providers in our MAC jurisdictions. On behalf of myself and Aline, I want to thank you for your participation. This concludes today's webinar. You may now exit the webinar. Thanks and have a great day.